Hello, good morning, everyone. Thank you very much to the organizers for inviting me to talk and for arranging this great meeting. So I'm going to talk to you today about a 54-year-old woman. She has very little information on her family medical history. Both her parents are deceased, and herself has a medical history of migraine, early menopause, and hearing loss. She mostly is bothered by her migraines, which is why she saw a neurologist in the first place. But this neurologist noticed first that she has quite short stature and a mild distal sensory motor on the lower limbs, pes cavis, absent Achilles reflexes, but bilateral Babinski side. On the other hand, she doesn't have any central neurological involvement, no gastrointestinal symptoms, and ocular and oculomotor examination is normal. She had a brain MRI due to her migraines, which show this predominant posterior, bilateral, symmetric leukoencephalopathy without gadolinium enhancement, which does not have any specific pattern. And because of a sensory motor deficit, she had that ENMG who showed a mild demyelinating sensory motor neuropathy. And that's when I first saw her, because the neurologist she first saw told me, well, I am referring this patient to you for the evaluation and management of a mitochondrial disorder. So very early in my neuromuscular upbringing, I was taught that you need to think a little bit about asking any genetic analysis, so I tried to do it. And obviously the mitochondrial disease hypothesis is very compelling. She has the migraines and all the extra neurological features. But I was a bit bothered by the association of leukoencephalopathy and demyelinating neuropathy, because if you really look, it's not such common in mitochondrial disorders. Obviously, there is MNGIE, but MNGIE usually or almost systematically also features a very loud gastrointestinal involvement. You are helped for the diagnosis with the thymidine phosphorylase activity, which is reduced. You can also have recessive mutations in SURF1, which are responsible for demyelinating neuropathy, but leaf syndrome, so involvement of the basal ganglia. Some early POLG mutations probably are also responsible for demyelinating neuropathy. In the literature, there is this one adult onset case with a heterozygous mutation and an MNGIE-like syndrome. And if you go in very much rarer genes, you have RM2B, the recessive, ophthalmoplegia, and demyelinating neuropathy. And if you really go looking very far, we talked yesterday about DARS2, who gives CNS involvement and axonal neuronopathy, but some works, such as this one, have suggested that on sural nerve biopsy, there is demyelinating features such as cluster or onion bulbs. So that's just really hypothetical. So our patient, Mrs. T, well, she has late onset, she has normal ocular motility examination, absolutely no gastrointestinal disorders, and normal thymidine phosphorylase activity, ruling out MNGIE, normal blood lactate, basal ganglia are not affected. So maybe it's not a mitochondrial disorder. And if it's not, then what could it be? Well, we're here. It could be maybe CMT+, but the NGS was negative for that. And it could also be a neurometabolical disease, but complete workup was negative for that hypothesis as well. So at that point, my thinking was not so helpful. So this is when I turned to our geneticians for some help. And I asked them, could you please help me with a genome sequencing, which was not that easy, because if you remember, she had no cadre available, so it was solo sequencing. But they accepted, and Marion Masingue, who's here today, worked on magic, and she found a homozygous version in COA8, which had a lot of arguments for being pathogenous, as it affected a canonical splicing site. It was extremely rare, and all the prediction tools classified it as pathogenous. And obviously, COA8 is indeed a mitochondrial gene, as it encodes cytochrome C oxidase assembly factor 8. It has been described in some patients. It's a very rare gene, but usually the patients showed a very severe, sometimes acute onset during childhood, and with this very specific cavitating leukoencephalopathy. Some patients are said in the literature to have peripheral neuropathy. It's never described further except in this article, where it is said that it is a demyelinating neuropathy. And in this article, the patients are 2 sisters and they have normal brain MRI. So in order to fully validate this COA8 variant, we performed a muscle biopsy. And the first 2 top pictures, A and B, which are HE and SDH staining, are completely normal. But picture C is COX and SDH staining, and it should be all brown, like you can see in the inserts, but it's blue because there's only SDH staining. There's no COX activity, which is confirmed on picture D, which is sole COX staining, and it's completely negative. Analysis of a respiratory chain muscle showed significant decrease in the complex 4 activity. And we also performed electronic microscopy on this muscle biopsy, which showed inclusions of paracrystalline and spherical inclusions in the mitochondria. Down left, you can see subsaccholemmal accumulation of mitochondria and elongated mitochondria on the right. And overall, these patterns, they correspond to structural mitochondria adaptation to complex 4 deficiency due to loss of function COA8 mutation. So to conclude, this expands the phenotypic descriptions of COA8 mutations, which can actually cause late onset post-symptomatic leukoencephalopathy and demyelinating neuropathy. I think we could also think about maybe asking more systematically brain MRI when exploring a genetic demyelinating neuropathy outside, of course, of the very classical gene, because it could help us characterize some more rarer genes or help us guide further investigations in case we don't have yet the genetic diagnosis. Combination of leukoencephalopathy and demyelinating neuropathy should prompt us to explore for neurometabolic disorders, some CMT genes, MNGI or MNGIE-like mitochondrial disease, but other mitochondrial disease should not be ruled out, especially if there is other suggestive symptoms of the mitochondrial disorders. And in those cases, I think muscle biopsy is still very useful to convince yourself that it is mitochondrial and also to validate some variants that you may found. And last but not least, sometimes don't overthink it, trust your colleagues' instincts. And on that note, I'd like to thank all of my collaborators and you for your attention.
Many thanks for this very interesting case. Any questions? Yes?
Thank you, very interesting, quite convincing, particularly for the muscle biopsy findings. 2 points. The first one, MRI changes in a patient with migraine can be partly explained. So did you perform spectroscopy?
Yeah, it was normal.
Yeah, it was normal. Okay, that's important to be kept into account. Second point,
we can come back to you later.
No. Complex 4 testing in the muscle biopsy. The respiratory chain,
the
complex 4 was reduced. Okay, thank you.
Thank you. Very interesting case. I wasn't sure I missed it. Did you have a EMG showing myopathic findings as well?
No, it's just
because there should be a
neuropathy.
myopathy and probably also.
Well, sometimes in our experience in mitochondrial disease, myopathic changes are not so easy to evidence, but she was completely, it was just demyelinating neuropathy. We didn't found any myogenic.
Mary?
I mean, we're always going to ask this, aren't we? Is there any nerve biopsies in these? Because, I mean, there's slow conduction, but we don't know it's demyelination.
No.
I mean, I know with the brain scan, but I think it's slow conduction, isn't it? Is there any nerve biopsies in any of the other cases?
No, actually, in the other cases, as I told you, like it always says peripheral neuropathy. It has never been explored further than that, and there's only one paper where it says it's demyelinating, but just on the EMG.
Because it's really interesting if you look at the actual, biopsies of people with mitochondrial disease and slow conduction. Some of them have a dysmyelination; they never myelinated properly, like the SURF1 and stuff. So it'd be very interesting to see what it shows, because the reason for it is quite interesting, actually.
Yeah.
Very interesting case. And I think the other thing is from this case, I mean, I think, I certainly think it's worth doing a nuclear mitochondrial panel in some of these patients if they're negative for the normal neuropathy panel.
Yeah, probably.
I think it's very interesting.
Maybe last question?
Thank you, very nice talk. My point is, how do you explain the incongruence between demyelinating neuropathy and the effect on the muscle, the accumulation of mitochondria? Which kind of mechanism could be?
Honestly, I don't know.
I mean, do you have any hypothesis on how to further investigate this?
No, as Mary said, probably maybe a nerve biopsy could help us to see what kind of demyelination and dysmyelinization is there really in the nerve. But I don't really have any explanations on how the muscle, the mitochondrial alterations induce the demyelinating neuropathy. No.
Yes, Mike.
Just a very quick question. Sometimes on muscle biopsies you can find nerve twigs and that look either myelinated or not myelinated. And I'm just curious if you saw any nerve twigs.
Yeah, it wasn't. No, it was a deltoid muscle biopsy, so probably we didn't get any nerve. But I don't think we had any. I don't think so. I'll ask. Yeah, but I'm not sure.
All right. Maybe very last question.
Short question. Why was the mutation missed by the exome sequencer? Or you
no,
wrote,
there was no exome sequencing. There was NGS panel for CMT, and it's not on the CMT panel.
Okay.